Well, I think we're ready to go. So welcome, everybody. My name's Steve Simpson, and as you can see, I'm one of the collective leaders, academic director of the Charles Perkins Centre and executive director of Obesity Australia. I'd like to begin, as always, by acknowledging and paying my respects to the traditional owners of the lands upon which we're all meeting. I'm here at the Charles Perkins Centre on Gadigal land of the Eora Nation, and I would like to pay my respects to elders past, present and emerging, as well as First Nations people with us today. Thank you for participating in this World Obesity Day event by the Obesity Collective. I'd like to thank in advance our remarkable group of Obesity Collective leaders who represent deep expertise across the many dimensions of the obesity challenge. This is a group, as you shall hear, who truly understands the need to tackle obesity from a systems perspective. We're here towards implementing the National Obesity Strategy. And you'll hear from our leaders in their quick-fire presentations how we're going to highlight a range of initiatives, the evidence and benefits for which are included in our Time for Action report, which was launched today, and in our federal pre-budget submission.
Email correspondent.
Need for action and national pressing than ever before as the rates of obesity along with the many comorbidities that limit the length and quality of life for many Australians. But the good thing, and you're going to hear that today, is that the timing is perfect to act. It's perfect because three critical things have aligned over the past 6 years. First, the Obesity Collective exists. We launched in 2018 and since then have built something really special in recognition of obesity being a systems challenge that's shared by all sectors of society. No one group can tackle it alone. And the collective is quite different. It's different in that the breadth and quality of our leaders and members means that we're able to arrive at consensus and identify the best suite of actions at multiple points in the obesity system, knowing that single interventions simply can't work. And importantly, we're here to help, not just to heckle government. We're a major resource for action. Secondly, there's been a massive increase in the understanding of what causes obesity. That's advanced enormously in recent years. There have been major strides in our understanding both of the biological mechanisms of obesity and how these mechanisms are hacked by the obesogenic environment. So we now know that the rise of obesity prevalence reflects a biological response with deep genetic predispositions to modern environments. And those environments promote unhealthy diets, stress, physical inactivity, and weight gain. But secondly, there's also been a huge increase in understanding in the mathematics of complex systems, such that we now know that solutions to obesity require addressing multiple points in a system, from key on-ramps and social determinants to the more proximate causes in the food and physical environment. And thirdly, when it comes to systems, we have a really clear understanding that there is a need for systems. Australia needs coordinated and sustained action across society, including local communities, businesses, non-profit organisations, media, healthcare, academia and governments. We need a range of actions from the personal to the community and the national. And the Obesity Collective is working to support this. That's what we do. And we've demonstrated, for example, in our Systems Action Hub, which in my view at least is a foundational piece of work that's arisen as the result of our collective efforts over the past 5 to 6 years. So we're here to help government mobilise and manage a systems response. And today in our fast-paced agenda, we're going to highlight some of the many leaders and strategies for action. So I'll hand over now to Annette Schmiede.
Have to unmute myself. Can you see and hear me, everybody? Tiff?
We can.
Oh, great. All right. As Steve said, my name's Annette Schmiede. I'm currently the CEO of the Digital Health Cooperative Research Centre. But I have had a long association with the Obesity Collective through my previous role with the Bupa Health Foundation as executive leader. And the foundation was a founding member of the Obesity Collective and was also a long-term supporter of Obesity Australia from when it was established over 20 years ago. I certainly don't need to tell this group of the impact that the condition of obesity has on our health and well-being. It can have serious impacts on people's quality of life and both their physical and mental health. As we know, calling alarm on the impact of obesity and the need for action goes back a number of decades. But it does feel like we are getting closer to 5 minutes to midnight when we see the current statistics and predictions on increasing rates of chronic disease and disability that are closely linked to obesity as the main risk factor driving some of these figures. And in actual fact, this week's Economist, which is just out, reports on a just released Lancet article that reports that over the last 30 years across the world, there has been a doubling of rates of obesity among adults and, more alarmingly, a quadrupling among children. Many poor and middle-income countries are now facing a double epidemic of malnutrition and obesity. All of society is affected, but equity is a major issue, with rates higher in communities with relatively low socioeconomic disadvantage, lower levels of education attainment, and particularly regional and remote areas of Australia affecting our Indigenous Australians. And what we are starting to see, of course, is business models that prey on the most vulnerable. We're seeing even a greater access to highly processed foods, a phone call away and delivered to your door. But we've come to learn that blaming individuals certainly doesn't work and actually sets us back. It has been a major distraction to a broader understanding of those obesity drivers. A recent study by World Obesity found the economic impact of obesity in Australia in 2019 to be $37 billion, or 1.7% of GDP. This is projected to reach $244 billion, or 2.5% of GDP by 2060, if action is not taken. In my current role, and as a board member of Obesity Australia, I can continue to work with the Obesity Collective to reinforce the need to work across all levels of Australia's healthcare sector, primary, acute, at all levels, both state, federal. This is not without its challenges, as we know, as we see the complex funding and myriad organisational structures that deliver health services across these state and federal jurisdictions. Delivering coordinated research, prevention and treatment services against this background is very challenging, but we're going to hear more about this today and why we are going to do this. But I'd like to leave a note that national leadership is critical. We can't underestimate the importance of the effective implementation of our National Obesity Strategy. And I'm going to hand on now to our next speaker.
Muting successful. Hello, my name's Andrew Wilson. I'm a dad. I live in the Blue Mountains, New South Wales, in Darug and Gundagara country. This past weekend, my wife and I did a few bee inspections of our hives, and the girls are looking healthy and they've done a great job. But our chickens have stopped laying, or they're hiding their eggs from me somewhere. So embarrassingly, I had to duck into the supermarket yesterday. Since we last spoke, my son's now in year 12, and now is working on assessment tasks. And I'm walking the delicate line between encouraging him to study, but also try not to add to his anxiety. And if you've been through that, it's a very, very fine line. Anyway, I'm a person with lived experience of severe obesity and was well on my way to not being around for long. Having weighed over 200 kilos with serious multiple comorbidities before I managed not to talk myself out of going to an obesity clinic in Western Sydney, that was about 5 years ago. I'm a very proud volunteer and board member of the Weight Issues Network since 2019, and over the last couple of years becoming the engagement and advocacy lead in an official capacity. The Weight Issues Network is the first organisation in Australia that speaks with the voice of lived experience of obesity, and we are proud to claim our space. We're raising awareness around the challenges and need for support, advocating for people's needs, creating a community of support and opportunities for people to share their experiences, stories, and insights to help others, dispelling dangerous media and social media weight loss myths and misinformation with evidence-based education, fighting weight stigma, bias, and discrimination, which is unfortunately very real in Australia in 2024. I'd like to acknowledge other passionate WIN members here today, Lisa Mullen, one of our WIN leaders, and our inspirational chairperson, Claire Mullen. They're not related, and who are at this meeting. You'll be hearing from them shortly. I'm very proud to be here side by side with them. 3 things I'd like you to know as a patient, as a parent, and as a voter. As a patient, I wasted many years trying to find my own solution for my obesity. I avoided the healthcare system after particularly stigmatizing meeting with a healthcare professional. Unfortunately, as a result of avoiding getting help, my weight and some of my comorbidities increased to chronic levels, and I went to some very dark places mentally. Eventually, getting help at the clinic I mentioned earlier, learning about my condition and losing some of the stigma, I was able to engage with treatments that were offered and began to build my life back. Surely, I have dropped a ton of weight and also medication, but my wife has pointed out that I'm much more fun to be around. I'm a big part of my community and I'm not hiding anymore. But what I'm most grateful for is being present for my teenage son. He's in year 12 and I no longer have to waste my mental energy battling my obesity every day. I'm truly present, and at this very important and vulnerable point in his life, I'm grateful for this second chance. As a parent, it makes me furious that the food industry still is allowed to sell and market unhealthy products that can lead to our children on a pathway to diabetes and obesity. If you think this is a conspiracy theory, as I did for years, watch Magda's Health Check on ABC iView. A shout out to Jane Martin, who you'll be hearing from shortly. How can we allow the food industry and lobby to do this to our children? How can we even consider it? In years to come, we'll be looking back at this and also ultra-processed food as we do to the tobacco industry. Let's take action now. We've got a mandate. It's called the National Obesity Strategy. Lastly, as a voter, I was delighted to hear the National Obesity Strategy being announced in 2022, but I'm frustrated to see inaction and inertia with getting it underway. Time is of the essence. This is one of those projects that will last much longer than an election cycle. This will be something that we can be proud of in future years. We began to make meaningful change at this point. Inaction will not only bear an undeniable massive economic cost for Australia, but also a personal cost in the lives of people like me, for our families and communities. We've come a long way and have changed our views on many subjects, such as multiculturalism, sexuality, and even mental health. It's now time for obesity. Thanks for listening.
Hi, My name's Tim Gill from the University of Sydney, and it's fabulous to follow the totally inspiring Andrew. As Andrew mentioned and the other speakers mentioned, we have a national obesity strategy, but it's not our first. Many people are surprised to learn that Australia developed the first national obesity strategy well over 25 years ago. And since then, there have been many national and state committees that have produced a range of recommendations and actions to address obesity. However, we're now in a much better position. We have a better understanding of the drivers of obesity, and we've learnt from what's happened over the past 25 years, both nationally and internationally. So we're in a much better position to do something about this problem. We appreciate now that obesity is actually a complex societal problem that requires more than just attention to individual behaviours. We know that to address it successfully, we need to address the whole system that contributes to the development and progression of obesity. In the past, this complexity has been used as a rationale for not doing something. Things are just too complex, nothing that we can do about it. But looking at what's been achieved through parallel problems such as road safety demonstrates how and what can be achieved by adopting a whole of systems approach to action. So just like obesity, it is now clear that the behaviour of individual drivers is not the only issue that influences road safety. To reduce the road toll, we need to address a wide range of interconnected factors around safer roads, safer vehicles, safer speeds, safer behaviours of all road users, together with better post-crash care. Addressing only one of these elements of the system alone will not improve the road toll, as the different factors actually build upon each other to create the desired effect. This is exactly the same when we're trying to tackle obesity. Actions can and should occur in one segment of the system, as the Obesity Collective Action Hub shows, but to be effective, all elements of the system need to be addressed. Now, not everyone will agree on the most important priorities, but we all agree, just like we do in road safety, that we need action that is comprehensive and, more importantly, needs to be initiated directly to avoid the situation becoming even more damaging to society. Small one-off initiatives won't suffice. Australia needs coordinated and sustained action supported by government leadership. And this national leadership, with a suite of prevention, treatment and stigma reduction interventions, such as set out in the strategy, could help shift the dial in Australia. Actions in this area would not only have benefits in terms of obesity, but clear co-benefits related to all chronic diseases, mental health, productivity, sustainability, and is in line with a whole lot of other government initiatives. But most importantly, focusing and creating healthy environments will reduce stigma, will help reduce stigma at least, will provide better healthcare options, and will help reduce health and social inequalities. So I'll pass over now to Joe, I think, who's our next speaker.
Joe and I will be taking the next session. Hello, I'm Steve Ellender. I'm from Deakin University, based on Wathaurong country. And as you've heard, and as we've learned from our research, we're thinking about obesity and its risks as having multiple drivers driven across multiple sectors of society. So if we were to think about tackling unhealthy diet, for example, we need to think about the whole food system, including agriculture, food processing, marketing, retail, transport, among many other things. And it's for this reason, projects tackling one single aspect of obesity just won't suffice. In fact, we need collaboration and contribution from multiple partners in the health sector, of course, but critically in those sectors beyond health. And the National Obesity Strategy, as Tim just mentioned, frames obesity as a systems challenge, specifically because we need to create healthier and more equitable food systems and a stronger and more equitable physical activity system that deals with this complexity. So while the National Obesity Strategy recognises the complexity is there, we're yet to see action to match this call to arms. Our work with local communities and across multiple layers of government has shown it is possible to actively improve the situation to actively prevent obesity when collective action is delivered across multiple systems driven through multiple sectors. And I'll hand over to Jo to add some more.
Thanks, Steve. So I'm Jo Mitchell. I was formerly worked in the New South Wales Department of Health. And in my experience of working within government, it's really clear that national leadership and action creates opportunities and momentum for implementing a strategy like the National Obesity Strategy for local departments of health. At a practical level, having the opportunity to learn from the experience of your colleagues from other jurisdictions, as well as contributing to the development of new initiatives, helps you to position your agency's contribution to a broader portfolio of actions. It can also create an environment where you benchmark your agency's approach against others. And this in itself can create some healthy competition, which can reinforce and further drive implementation ambition and impact. So as we've already heard, the National Obesity Strategy is really clear that addressing obesity needs a systems and a multi-stakeholder approach. So this includes community, non-government, academic partners, and it must also include government agencies outside of the health sector. But we know that this has always been a challenging aspect of implementation. One comment that I would make is that when you're inside the tent, so when you work within government, you have a different perspective on implementation. And for our academic, non-government and community partners, the system can be opaque. And so it can be very difficult to see progress on implementation.
Thanks, Jo. And we're in the fortunate position where we have quite a deal of evidence about what it takes to support obesity prevention. We know that successful, sustainable prevention efforts need dedicated resources. They need collaboration with clear objectives, strong policy, governance and communication support, and a capable workforce and community with clear monitoring and reporting of progress and impact. If we activate these elements, we'll foster and encourage learning across jurisdictions, as Jo just mentioned, and shorten the time it takes for us to learn lessons in one place and apply them universally. Critically, piecemeal efforts are counterproductive. They divert our limited resources, they reduce our impact and create discouragement from those key stakeholders who want to help improve the health of our nation. We have a clear opportunity to leverage the National Obesity Strategy and provide bold leadership through which governments can deliver coordinated and collective action. And critically, we can enable significant change. In doing so, in taking this position domestically, Australia has the opportunity to achieve our national strategic goals, but also to demonstrate the global leadership that we've been famous for in the past in improving the health of our population, reducing the risk and the burden of obesity, both for current and future generations.
Right. So just to round off this brief presentation, one of the Obesity Collective's policy asks within the budget submission that we're talking about today asks for investment in leadership and collaboration to support the implementation of the National Obesity Strategy. The strategy does already note that it's important to align with national prevention mechanisms connected to, for example, the National Preventive Health Strategy. This must also consider and establish new ways of supporting system-wide implementation that can build an aligned movement for change and engage stakeholders and build collaborative relationships to get the best value from investment across the board, and also to create more transparency about how the strategy is progressing against its aims, and to provide more opportunities for broader discussion on the gaps and opportunities for implementation. So that's us. So I'll now hand over to the next presenter.
Hello, everybody. I'm Jed Carney, the Assistant Minister for Health and Aged Care. I'm recording this message in Canberra on the lands of the Ngunnawal and Ngambri peoples. I pay my respects to elders past and present and extend that respect to any First Nations people with you on World Obesity Day. Firstly, I'd like to start by acknowledging our wonderful hosts today, the Obesity Collective, for all the work you do to address the consequences of obesity on the health and well-being of Australians. Obesity is a complex condition. It's influenced by social, environmental, and economic factors. It's a condition that is found all around Australia and all around the world. Tackling obesity is key to unlocking healthier, longer lives for so many people. Many years ago, I was a nurse at the Austin Hospital. I saw firsthand the challenges that obesity can pose for an individual, for their loved ones, and the people caring for them, and for the healthcare system itself. Australia has one of the highest rates of obesity in the world. In 2022, 66% of adults aged 18 and over, and 28% of children and adolescents aged 5 to 17 were living with overweight or obesity. Now, if the current trend continues, more than 18 million Australians, that's 2/3 of the population, will be overweight or indeed obese by 2030. But we also know that there are different populations within Australia that have a high prevalence of overweight and obesity and therefore need extra support. This includes people living in regional, rural and remote areas, people with mental illness, people from culturally and linguistically diverse backgrounds, and the LGBTIQA+ communities. It's why the work of the Obesity Collective as a peak body for obesity in Australia is so important, transforming the way Australia thinks, acts and speaks about obesity. You're at the forefront of a conversation and growing recognition that obesity is a systems and societal challenge, not a personal failure. Your vision to create a network for collaboration to change the narrative around obesity and advocate for action to create healthier environments and better support from the health system is absolutely key to creating change. It's a vision that this government shares because we know that obesity just doesn't impact our health system. It impacts our communities, society, and economy. In one study, it was estimated that obesity may cost the Australian community $87.7 billion by 2032. It's because of these reasons and the work that you all have done that the government released the National Obesity Strategy. This is a 10-year framework to prevent, reduce, and treat overweight and obesity in Australia. There are two key 2030 targets: halting and reversing the rise in obesity in adults and reducing overweight and obesity in children and adolescents by at least 5%. Labor's committed to working side by side with the Obesity Collective and the broader sector on these targets. It offers a way forward to tackle obesity through a better food system, getting Australians active, improving our built environments, providing person-centred support through the health system, and taking action in a non-stigmatising way. But as I am sure you would all know, addressing obesity will need the collective effort, expertise and efforts of everyone here today. Today's virtual event, the Obesity Collective's 5th, brings together a range of experts in prevention, treatment, lived experience and government from across the country. The work you all do in the community to achieve the ambitious goals of the strategy should be commended. I thank you all for being here today to talk about this significant issue that is affecting the health and well-being of Australians, and for your ongoing dedication and commitment to address overweight and obesity. I want to absolutely reassure you of the Australian government's continued support towards this important issue and your work. It's only fitting that the theme of this year's World Obesity Day is Let's Talk About Obesity. And it's about starting conversations, looking at health, youth, and the world around us to see how we can address obesity together. And that's precisely what today's event is about. So I urge everyone to be part of World Obesity Day. Let's have the conversation. I wish you well in your discussions, and I look forward to hearing the outcomes and your ideas for a way forward. Thank you. Hello, everybody.
Hi, everyone. Hard act to follow, the Minister, but I'm going to talk about a health levy on the manufacturers of sugary drinks. And thank you very much, to the collective and Tiff for inviting me to speak about this issue, which has been receiving some attention. And we know that sugary drinks are a problem because they're the leading source of free sugar in the diet of Australians. The World Health Organization recommends to limit the intake of free sugar to reduce the risk of dental caries, excess weight, and type 2 diabetes. So we know that nearly half of the excess sugar in our diets is coming from sugary drinks, and that regular consumption of sugary drinks leads to health problems, including weight gain. So the World Health Organization has recommended that governments implement a levy of at least 20% on sugar-sweetened beverages to increase the price and to incentivise reformulation, as they've done with the UK model. Sugar-sweetened beverages are a broad range of products. They include carbonated soft drinks, which people often are aware contain sugar. But what Australians are not as clear about is that energy drinks, sports drinks, sweetened juice drinks, ready-to-drink teas and coffees, milk-based drinks, and waters are also sweetened with free sugars, and Slurpees, which can have very, very high rates of sugar. So this policy is supported by the World Health Organization, who've released a global tax manual on sugary drinks. Last year in December, they also published a policy document which recommended that governments implement this policy. The National Obesity Strategy, 2 years old today, also recommends that the Australian government consider policy approaches that use price to reduce consumption of sugary drinks. We now know that 100 countries in the world have implemented some kind of levy on sugary drinks. Coverage is highest in low and middle income countries, and it's a cost-effective tool to reduce consumption. And it not only has health benefits, it has economic benefits, and it is also equitable. And I'll talk a little bit about that in a minute. So it's, as I said, more than half of the population in the world is covered by sugary drink tax. Young people and low-income earners are the most responsive to a price change. And these are the populations who are suffering most from overweight and obesity. They're also, the individual and their family pays the majority of health costs associated with overweight and obesity, higher than government. So if there's reduced health costs and reduced health risks and improved health in these populations, there is a benefit in how much they pay for treatment as well. So that's important. And young people and people on lower incomes are very responsive to price changes. What's happened in the rest of the world? Well, we know from Mexico, which was one of the first countries to introduce a levy, that this had a positive impact on oral health, which is now coming to light with less patient visits for dental cavities recorded after the tax came in. That low income populations were the ones who were most responsive to the tax. So that supported those groups to be healthier, which was really important. In the UK, there was a huge drop in the amount of sugar in drinks. Even before the policy was implemented, consumption of sugary drinks declined. And now there is some evidence that the levy being in place for since 2018 has had some impact on reduction in obesity in some subpopulation groups of children. So that's really important and shows that it's having an effect. Public support is high. In 2017, a survey showed that 3/4 of Australians supported a levy on sugary drinks if the process were used to fund obesity prevention initiatives. And there's certainly lots of ideas on the ways that this funding could be spent in the Obesity Collective's budget submission and also in the National Obesity Strategy. This is a widely supported measure. I think importantly, it's supported by the Australian Council of Social Services, but other medical groups such as the AMA, Cancer Council Australia, Diabetes Australia, and the organisation that I lead, the Food for Health Alliance. We've been calling for a levy on sugary drinks for many years now to address the issues. So thank you very much for the opportunity to speak today, and I'll pass on to the next speaker.
Hi everyone, I'm Caroline Miller and I'm going to talk about another of our prevention priorities, and this is mandating health star ratings across the packaged food supply. We're also very interested to see it enhanced to ensure that it aligns with dietary guidelines and doesn't inadvertently promote unhealthy foods. So we know labelling of packaged food is a great strategy. It provides consumers with transparent, accurate information about the food that they eat, and that's crucial for improving health outcomes. The other reason that labelling is important is because it incentivises manufacturers to improve the health profile of foods through reformulation. So the Health Star rating is an important tool to help consumers identify quickly and easily healthy foods and to compare packaged foods within food categories. So we know that what we have at the moment is not effective or efficient. So the Health Star rating system is currently voluntary and it's not being used consistently or comprehensively. And only 36% of packaged foods are currently using the label, and we haven't seen an increase over the last 3 years. Further to this, it also appears that manufacturers are using the labels as a marketing tool, selectively applying them to promote higher scoring products. So this is confusing for consumers and it doesn't make it clear or easy for them to understand the most healthy products. So we're not getting the most benefit that we could be from the system that we have in place. So internationally, we know that food labels are successful. There are 16 other countries that have already mandated front of pack nutrition labels. It's recommended by the World Health Organization as an effective and a cost-effective intervention for obesity prevention and also for prevention of non-communicable diseases. We also know there's really high public support and expert support. So front of pack labelling is supported by over 30 peak bodies and public health organisations. It's also widely supported by the Australian public, with 3 out of 4 Australian adults in favour of government action. So in summary, it's time to mandate our Health Star ratings and also strengthen them and apply them across our food supply. Thanks very much.
Hello, everyone, and thanks for joining today. So I'm Elizabeth Kaleja. I'm the National Heart Foundation of Australia. I'm the Senior Advisor for Physical Activity. And the main item I'm going to talk to you in prevention section today is a national approach to support community-led action and leadership. So this includes community education. So the issue here is that we have a need for an approach to support grassroots local health and wellbeing leaders to help reduce obesity risks and help to support people across the community, also supporting community mobilisation and understanding of this issue. Now, community-led initiatives are featured across Australia and in place help to improve health and wellbeing and reducing obesity risk, as well as helping to support people with weight management. However, there is limited coordinated mechanisms nationally for sharing these lessons learnt and best practice and collaborations where health and wellbeing programs are easily identified and accessible by community to help them with their health and wellbeing. We need further mechanisms and investments in this space. And we also need to help support the community informed decision and help with local leaders and also to catalyse collective change. We also really need to think about how we support our community and bring them in for consumer-informed ways in moving forward. Place-based projects across the country are recognised as a really high priority area that we need to work on. And to help this, we need to support grassroots leadership, an important place, which is an important place of the systems puzzle. Now, across these systems, we identify as well as helping support community to engage and help those to make change. that our environment plays a big place in this communication and conversation, particularly the design of our built environments, as they have a major influence on people's health and well-being, enabling them to lead active lives and also for access to healthy and fresh foods. Now, at the National Heart Foundation Australia, we had a What Australia Wants survey, and one of the key areas that people were highlighting was access to local places. So 77% of respondents really highlighted they wanted easy proximity to food, neighbourhood safety, and access to public and open spaces to help them to achieve their health and wellbeing goals. So we need to support community action and invest in this area. We need some resources for local communities to proactively reduce obesity risk in the community. We need to help the public to better understand the many drivers of obesity in our obesity systems map and the multitude, and we can't do this all on our own. So we need multiple areas of work to be done, and also to directly help reduce stigma. But we can't start from scratch. And we know that there's a multitude of organisations who is doing a lot of work across the country with community. And we need to build off this historical work in prevention, treatment and support, stigma and mental health. So community-led interventions and ability for treatment and support and social connection is highly important. And we have multiple organisations such as the Weight Issues Network. Heart Foundation is working in that space to help support people from social connection with physical activity, and Heart Foundation Walking. We've got multiple other organisations such as Deakin Global Centre for Prevention and Health, and Western Sydney Diabetes, and a lot of collectives and organisations across the country. So one of the most important things as I wrap up is that Australians really want to see more happening to help support them. And again, the What Australia Wants survey, up to 72% of respondents reported that community and community facilities were important parts of connection and health for them to be able to achieve their health and wellness goals and achieve a healthy lifestyle. Now, the approach should be done bottom up, and also working at different multi-systems level with not-for-profits and also government to help to improve outcomes. So thank you, and I'll pass on to the next speaker.
Catherine is just doing a bit of media for us at the moment, so we're going to come back to her in a minute. We're going to go on to the beautiful Lisa in her video.
Hello, my name is Lisa, newly admitted lawyer a year ago through the Supreme Court of Queensland. I work for Queensland Government in National Heavy Vehicle Reform, Policy and Legislation. The first 50 years of my life were a good indicator for weight management failings, resulting in me becoming 141 kilograms. I was pretty much a ticking time bomb, being only 157 centimeters tall. I'd like to touch on how I changed, and this came in the form of what the right support looked like for me, and I'd only discovered it 3 years ago. Success arrived through a great medical practitioner. So how did they make a real practical difference in my life? Well, it's quite simple, using appropriate interpersonal skills. She took time to listen and had a genuine interest in trying to help me. She understood my circumstances and acknowledged that I had tried everything in the past. For example, appetite suppressants, having a lap band fitted, and also diet and exercise. So even though I'd consistently failed, she remained impartial and non-judgmental. She suggested RNY gastric bypass as an option, and I'd never heard of that. She explained the ins and outs of the medical procedure in plain English and in a no-pressure environment where I could comfortably ask questions. I was really impressed with her level of technical expertise, which I believe extended beyond the scope of a general practitioner. She also provided a holistic experience by introducing her collaborative networks she relied on, for example, the Australian Taxation Office, and also Q Super, my superannuation fund, that I could actually attach to so that I could have the operation done. I could see she kept her networks fresh throughout knowing who to go to regarding specialist referrals. She took immediate action. I was sitting in her rooms and she picked up the phone to book in time for me with the bariatric specialist within that week. She kept in touch, she provided follow-up care and supported me during the difficult times. She was proactive in addressing some of the side effects, so things like heartburn, And she also sent 3 monthly reminders for blood analysis to check the absorption levels of essential minerals and nutrients were functioning properly. She introduced me to groups and societies to share information, giving me a level of empowerment. She gave me the right support from the beginning, and she remains my one-stop shop today for information. There was a significant psychological shift from my previous failings, but my GP made it okay by navigating me through that. She really was a critical safety net and offered information without me having to ask. So what has this level of support done for me? Well, it's been a real game changer. I'm now 88 kilograms. I have confidence and health to fully engage in a rich life. My whole career has changed. I barely had enough courage to finish law, let alone enter the legal profession, which brings with it its own challenges, but I have now done this. I actively seek out opportunities to better myself. And because of that, I can now help others both professionally and personally. Thank you.
Hi, everyone. Apologies, I think it's up to me. Is that right, Tiff?
That's right. Go for it, Catherine.
Okay, thank you. So my name is Catherine Backholler from Deakin University, the Global Centre for Preventive Health and Nutrition, and I'll be talking about comprehensive government regulation to protect children from unhealthy food marketing. And this is because we have really good evidence now that marketing influences food choices. So Australian kids are exposed to unhealthy food marketing every day as they go about their daily lives, whether in the physical environment or the digital environment. And our studies have shown that it's children with a lower socioeconomic background that are exposed to higher volumes of unhealthy food marketing. We have really good evidence that the marketing of these unhealthy foods negatively influences dietary intake, which of course then increases the risk of diet-related disease right across the life course. The WHO just released a report on this, more than 100 studies really summarising these negative adverse health consequences, or at least potential impacts of unhealthy food marketing. In Australia, we're reliant on industry codes of practice, which time and time again have shown to be completely ineffective. So it's not surprising that 7 out of 10 Australian adults want governments to step in to protect children from unhealthy food marketing. In terms of what's going on around the world, we know that international evidence and recommendations, including those from the WHO, are to protect children from unhealthy food marketing through the implementation of a comprehensive government-led regulation which restricts children's exposure to unhealthy food marketing, so what they see across all media and settings. So this includes broadcast, TV, radio, digital media, really important as kids spend 2+ hours every day online, retail outlets, outdoor, sponsorship, and also product packaging. And I'll make this really important point, and that is that we need to address unhealthy food marketing that children see, not just what is directed to them or intended for children. We obviously need a definition of unhealthy foods if a policy like this was to come into play, and we obviously have the Australian Dietary Guidelines, which will be released in 2025 and should align to those, both the current ones and the revised ones. We have good international examples of government-led marketing regulations, including in Chile. So in 2016, we have the Food Labelling and Advertising Law, and in the UK, which has been enacted but not yet implemented, which is a ban on all unhealthy food marketing between the hours of 6 a.m. and 9 p.m. at night, and all marketing that is being paid for online where an unhealthy food product is in that marketing content. And these international food marketing laws have shown to effectively reduce children's exposure to unhealthy food marketing and reduce the purchase of unhealthy foods, particularly the evidence coming out of Chile. So Australia really could be an international leader with strong marketing laws that prioritise our children's health over corporate wealth, and that's what we're calling for as part of the collective. And I will now pass to Lisa. Claire.
My name's Claire Collins, and I'm a Professor of Nutrition and Dietetics at the University of Newcastle. Clinical guidelines for the treatment of obesity are currently in development, and these new guidelines will be an essential tool to guide clinical care. We can't expect doctors, healthcare professionals, and individuals to address the challenge of comprehensive treatment without guidelines. And these need to be informed by the best available evidence, clinical standards, and offer treatment options for people living with obesity. But we actually have had guidelines before. The 2013 clinical guidelines for obesity have now been rescinded for the past 6 years, and we're keenly waiting the new ones. When obesity guidelines are created and printed, and that can be a process that takes years, but there's no funding set aside to develop the educational programs, clinical tools, the decision-making algorithms, and the supporting resources and the funding to actually roll them out, then all of the work is actually wasted. Doctors, health professionals, and the public really are left with an intangible resource, and it's been wasted, all 230 pages. There is a risk that the current guidelines won't be used if they're not shared widely and easily. If the resources are not there so that clinicians can tap into them in real time, they're busy and they need to be able to access them within a consultation. Guidelines and training are also needed to address the issue of obesity stigma. And we've already heard about that this morning. And it really is a major barrier to accessing the care that's needed and appropriate types of care. This really must be considered in not just the development of the guidelines, but the educational resources and the tools for healthcare professionals. Just imagine if you had a family history of bowel cancer. You're experiencing some symptoms and you were worried. You went to see your GP and said, should I be referred to a specialist? Should I have a colonoscopy? But the advice you were given, because there were no guidelines, was that instead, how about if you cut down on your processed meat, moderate your total meat intake, come back sometime in the future, and we'll revisit whether or not you should be referred on for a colonoscopy. Now, you might think, well, that is ridiculous. That would never happen. And clearly that is crazy. Yet this is the experience for many people who are living with obesity now. No connection to current available effective treatment is provided. So we're calling on for greater resources for the implementation and dissemination of the new guidelines once they're here. The healthcare system needs to be able to deliver high quality, evidence-based, multidisciplinary care, and this needs to be supported by the specific resources, including a training hub that will have these tools, these algorithms, and importantly, access to education on how to use the clinical guidelines. This will help translate the major investment that's underway in developing these new evidence-based guidelines and make it meaningful that people, when they touch base with the healthcare system, they'll be directed to effective clinical treatment for obesity-related health and well-being.
Thank you, Claire. That very much dovetails into what myself, Dr. Terry Lynn South, and my co-presenter, nurse practitioner Catherine Smith is going to be talking about. Just a little introduction. I'm Terry Lynn. I am a GP and I am the current chair of the RACGP specific interest in obesity management. I'll just talk first and then hand over to Catherine. As Claire said, we're eagerly awaiting these new guidelines. They are expected to be a valuable and essential tool in the implementation of the National Obesity Strategy and to guide clinical health care. But we cannot expect individuals and communities to start to address the challenge without guidance on the best evidence, standards, and options for people with obesity. There is a real risk that these eagerly awaited guidelines won't be used if they are not communicated, shared, and we need resources to be able to implement the recommendations. They need to be easy for the busy healthcare practitioner to implement. And we also need to understand that stigma is a major barrier for our patients living with obesity to access appropriate and needed care. And this does need to be considered in the development and dissemination of the guidelines, making sure we provide appropriate education resources and tools for healthcare practitioners. So we were asking, as part of our action, for the government to provide funding and support for healthcare professionals to be able to provide this quality care. We are asking that there is an official clarification and announcement that obesity as a chronic complex healthcare condition can and should be managed with current GP management and enhanced primary care plans, as well as eating disorder resources be available for people with binge eating disorder, which overlaps with obesity and is actually the most prevalent of eating disorders. Catherine, you have some ideas to share too.
Thank you, Terry Lynn. Thank you for the opportunity to present on World Obesity Day. As a bariatric nurse practitioner working in this area of healthcare for the last 12 years, I'm so pleased to see the improvements our collaborations are getting traction with. Within clinical practice, we are seeing that patient-centred approach, not programs or one-size-fits-all services, are improving the health outcomes of our clients. When we consider our clients' experiences within the healthcare system and their community in their treatment, we are seeing improvements in well-being and health. Strengthening Medicare and the scope of practice reviews need to consider the barriers and potential health outcomes of a well-delivered bariatric healthcare, as these services can positively improve the health of our continually growing population of Australians with a weight issue. Nurse practitioner clinics, telehealth services, nurse-led clinics and allied health services are improving access to weight-related health services. My clinic, like many others, are working within the current barriers to achieve positive health outcomes, but our services could be much improved or increased considerably. My service has had a 330% growth in our client numbers in 2 years, with 76% of our clients self-referring. This is good to see that so many Australians are seeking services and having the faith that with us they can experience the improvements in their health. Telehealth may be considered a key part of this increased access. Nurse practitioners have the ability to support clients across wide areas of our country in which primary health care and specialty bariatric services are less accessible. Telehealth funding should be accessible to appropriate bariatric medical models for clients to access, as rural and remote Australians should not have their access limited by their geography. A certification process for all health practitioners working in bariatric healthcare, which acknowledges the training and continued education, is a requirement should be a requirement for specialty area, as we see in many other specialty fields. A well-delivered bariatric healthcare can be life-changing for Australians. Many of their stories are inspirational to us who have the honour of providing them their healthcare. We now have the ability to do this, so let us continue to grow these inspirational stories. Thanks, Terry Lynn.
So in summary, we are asking for a whole of health approach, as is the standard of care for other chronic health conditions. For example, mental health, cardiovascular disease and eating disorder. The same is required for obesity. These treatments are evidence-based and are supported by economic analysis. We are suggesting that there is an ethical imperative to urge people to not just lose weight, but to do so with the appropriate tools, evidence-based options and referral pathways to do the request of asking people to lose weight without those supportive measures actually risks more harm than good, and the evidence shows that it's not effective. Our current approach is ineffective, inefficient, and wastes resources. We can do better. We must understand that stigma and that is being perpetuated by not actually having evidence-based services and quality information available for people living with obesity. Thank you.
Hello, my name is Samantha Hocking and I'm an endocrinologist with an interest in treating complex obesity and an academic at the University of Sydney. And I'm also the current president of the National Association of Clinical Obesity Services. As we've heard so eloquently described by our colleagues with lived experience, Andrew and Lisa, those who live with severe obesity live with multiple chronic health conditions that incur high healthcare costs and that require a multidisciplinary approach to care. As we heard from the Assistant Minister, obesity disproportionately impacts those in our society who are the most vulnerable. As they both described, this is a chronic health condition that cannot be self-managed, but it needs to be treated with empathy in a multidisciplinary setting. Obesity is the most common chronic disease that affects Australian adults. We have heard that that affects a third of the adult population. To put that in context, that's 8 million Australians who are currently living with obesity. Now, despite this, a survey conducted in 2017 identified only 16 public hospital-based obesity treatment clinics across Australia. Almost all of these were located in major cities. Most have a long waiting list. In some cases, the waiting list is years. And unfortunately, most are also inadequately resourced. What this means is that most Australians do not have access to evidence-based therapies for the treatment of complex obesity, including pharmacotherapy and bariatric surgery. A very stark fact about bariatric surgery is that less than 5% of bariatric surgery performed in Australia is performed in public hospitals. This is the situation for adults, and unfortunately, the situation for children and adolescents is even more severe, with less services available. So we are asking for a call to action. All health services across Australia must have access to publicly funded multidisciplinary obesity care. This should span primary through to tertiary care, and this must be included in the National Health Reform Agreement. Thank you.
Hi everyone, I'm Liz Holmes-Truscott, Deputy Director of the Australian Centre for Behavioural Research in Diabetes, and I'm focusing today on the issue of weight stigma. So we've heard what evidence-based and system-level obesity prevention and management action is so desperately needed in this country. But in taking any action, we must also ensure we're not only addressing the harmful issue of weight stigma, but not contributing to this problem. It has already been said that weight stigma is a major barrier to equitable healthcare access and support for people living with obesity. Indeed, there is a wealth of scientific evidence and lived experience reports showing the harmful impacts of weight stigma, including those reported in this very rapid talk session. At an individual level, we see that weight stigma is associated with considerable mental health consequences, including increased depression and anxiety symptomology. It can lead to avoidance of healthcare, delayed presentation and screening, as well as lower quality of care provided. Weight stigma is also associated with worse physical outcomes, and it can actually perpetuate the problem of obesity, as it is associated with disordered eating, reduced exercise, and weight gain. So weight stigma can actually negatively affect people's ability to manage their weight. It can also exacerbate socioeconomic disadvantage through reduced educational, social, and employment opportunities. At a societal level, weight stigma can negatively impact public and political support and funding for the much needed action that we've spoken about today. Weight stigma arises in part from a lack of understanding around the many drivers of obesity, including the strong social, biological, historical, and environmental factors. It can also be driven by the overemphasis on personal responsibility, and it's reinforced by a simplified narrative whereby shape and size are incorrectly and harmfully assumed to equate to behaviour and effort. Weight stigma needs to be more widely addressed in both society as well as within the healthcare system. However, there is currently very little investment nationally on understanding, monitoring, and addressing the issue of weight stigma, bias, and discrimination. We need a range of actions to help bring an end to weight stigma and its harmful impacts. In the first place, we need to address weight stigma within clinical care through guideline implementation and training for health professionals. We know that stigma is a barrier to best practice early intervention and treatment for obesity, as well as related chronic conditions. Yet weight stigma is prevalent within the healthcare context and commonly perpetrated by health professionals, often without realising. This needs to change to improve people's care and outcomes. And health professionals are really well positioned to not only reduce their own stigmatising practices, but support individuals who are presenting having experienced weight stigma in the broader context of the community. To take action, we need to include weight stigma as an official priority in developing implementation plans, materials, and communications for new clinical guidelines. This could include training and resources aimed at increasing non-stigmatising practice, as well as enabling health professionals to recognise and support individuals who are suffering the harms of weight stigma. More broadly, we need to continue to acknowledge the occurrence of weight stigma and ground all prevention, management, and support guidance and implementation plans within this context. Best practice guidance that is framed in a way to consider and help address weight stigma will help reduce its harms and improve clinical care. Healthcare providers have an important role to play. They can powerfully perpetrate the issue or counter weight-related stigma in their interactions with clients. A better understanding among health professionals of the complex drivers of obesity, the lived experience and benefits of person-centered care, and non-stigmatizing practice will ultimately lead to better outcomes and care. Thank you very much.
Hi, my name is Xochitl de la Piedad Garcia. I'm a researcher in weight stigma at the Australian Catholic University. And I'm going to be talking about the need for inclusion of expert advisory groups in the development and implementation of the National Obesity Strategy for weight stigma. So as Liz very eloquently discussed today, weight stigma is a major issue affecting people living with obesity or living with in larger bodies. And we've heard a lot of people today talk about how obesity, we understand now the drivers of obesity to be quite complex. Yet the public narrative in the public spaces in society doesn't reflect this understanding. So we need to start moving away from a narrative that blames individuals and moralizes weight, and start having the public discourse on obesity to reflect our understanding of the complex causes of obesity that we've been discussing today. This is because we need to tackle weight stigma, which imposes barriers for people to engage in health-promoting behaviors. Liz talked about all of those, like barriers to exercising, barriers to seeking healthcare, and many other issues. So, although many of us would agree then that weight stigma is bad, the reality is that the beliefs that underpin weight stigma, the beliefs about the blame, individuals being to blame for their weight, is pervasive in society. It's embedded in every aspect of the way people in society think and work. So we can see it in the media, we can see it in the way spaces, physical spaces are arranged, we see it in healthcare messages, we see it in families and interpersonal interactions. And this is because this complex understanding hasn't quite filtered down to the public. So this makes it difficult to change our stigmatizing behaviors. So despite this understanding, many people are not aware of how to make these changes. We believe that the National Obesity Strategy presents a very good opportunity to start changing the narratives and exposing the general public to the narratives that we've been discussing today about the complexity of obesity. So we are calling for an action to include advisory groups made up of weight stigma researchers and lived experience experts that may help with the implementation of the National Obesity Strategy and the clinical guidelines that are developed, so that we design stigma-related materials. We also collaboratively create principles and review the communications about the National Obesity Strategy or any interventions programs that the National Obesity Strategy develops, and so that we can share emerging evidence around our understanding of stigma, its effects, and ways to prevent it in our practices as healthcare professionals, as researchers, or even as media voices. So this team of experts, both lived experience and research experts, can help identify opportunities to address stigma and make sure that the actions and investments from the government are not unintentionally causing harm by perpetuating stigmatizing views of people living in larger bodies. And with that, I think Blake is next.
I'm not Blake. I'm filling in for Blake. I am Dr. James Kite from the Prevention Research Collaboration at the University of Sydney. And I'm talking to you about mass media guidelines and engaging with them. So as Ashil said, stigmatizing language and imagery is everywhere in our society, and the media plays an important role in perpetuating that. Stigmatizing images and framing are very common when reporting on obesity in Australia and globally, and these just reinforce stereotypes around individuals being to blame. Things like disembodied imagery of people with obesity without heads, and doing things like not exercising or eating food and that sort of stuff that just perpetuate standard narratives around the causes of obesity. And sometimes even quite well-intentioned media initiatives can actually perpetuate stigma. There are national and international media guidelines around avoiding stigmatizing imagery and language in media, including from the Obesity Collective, but they aren't used very widely. And instead, what we see is these terrible headlines and imagery. That being said, we do know there is interest from media organisations around getting clearer guidance on what's appropriate for framing, for imagery and terminology. So what we'd like to see is supporting the development of a framework and a target engagement approach with the media to reduce stigmatising reporting on obesity, and actually working with the media in developing guidance for greater impact. And in doing this, we know that by engaging with the media, we're going beyond just developing these guidelines, that we'll actually be engaging with them to support uptake of best practices. And we know journalists are generally not intending to cause harm. They don't want to be using stigmatizing language and imagery. And they're simply just not aware of the science of obesity or the impact, fully appreciate the impact of their reporting on stigma. We also know that many journalists and media teams are busy and don't know what non-stigmatizing reporting looks like in practice. So by developing these guidelines and also engaging with the media directly, we're going to make it easier for them to do a better job reporting on obesity.
Hello everyone, my name is Dr. Kimberly Norman. I'm an obesity health researcher at Monash University, as well as someone with lived experience as well. The first issue I'm here to speak to you today is that we need to officially recognise the need for monitoring and surveillance on weight stigma in our society. Specifically, we need high quality evidence on weight stigma in society, and we need monitoring to support national actions to reduce weight stigma and track progress over time. The main actions that are called for is that we need an official statement from the government about the importance of research to help address and better understand weight stigma as a priority. This would make it easier for researchers to initiate valuable projects that can help people living with obesity. This would also significantly help researchers to be able to point to an important gap in strategic priority. Many people don't understand why weight stigma is so important, and weight stigma could hinder support for research. In addition, the topic of obesity, specifically including weight stigma, could be considered for the next round of MRFF priorities, which are set every 2 years. This is really important because the recognition of the value of evidence-based insights will help researchers to apply for funding and create collaborations to help reduce stigma in Australia. Also, the monitoring and reporting can help with accountability and understanding the implementation impact. The second topic is the issue with legislation on weight discrimination and that it should be reviewed. So the issue is that research shows people with obesity will be less likely to be hired, are lower paid, have fewer education or employment opportunities, and are often bullied in their professional and personal lives. From my research, I know that weight discrimination can impact all aspects of an individual's life, including lower income, depression and anxiety, and refusal to attend health appointments for fear of discrimination, further lowering the quality of life. Weight stigma can exacerbate socioeconomic disadvantage through impacts on mental health, social inclusion, and reduced educational, social, and employment opportunities. Now, the National Disability Discrimination Act covers obesity where defined as a loss of functioning of a person's body or part of the body as a disability, and therefore a person whose weight impairs his or her functioning is covered. However, a disability designation is not appropriate for all people who would be considered to be living with obesity. People discriminate based on looks, not ability, which is the issue. Also, unfortunately, in this approach, those with severe obesity who are most likely to have their weight impair their functioning and so would potentially be considered to have a disability may not be protected for employment. Yet, at the same time, people who are severely affected by obesity are not allowed to have NDIS, the National Disability Insurance Scheme, support. The current legislation is not clear and does not appropriately categorise or support the people that need it. This is not helpful for individuals or organisations such as employers to understand people's rights. And we also know that many employers don't currently have body weight considerations in their D&I strategies or training. The action that is needed is the support for a review of the appropriateness of the current discrimination legislation related to obesity. This is extremely important because legal clarity can help organisations adapt their internal processes and D&I strategies to help avoid harmful discrimination. People with obesity can have a better understanding of their rights and options related to discrimination with this, and this will help reduce discrimination in society, which can further inequities. Thank you. I'll pass back to Tiff now.
Hello, I'm Claire Mullen from the Weight Issues Network. I'm a Scot, if you can't tell, who is delighted to have found myself living and working on Wajak Norbuja in Perth, Western Australia. In my day job, I'm the Executive Director of WA's peak health consumer organisation, Health Consumers Council, and I've worked in health between here and the UK for over 20 years. Like many women of my upbringing, I have plenty of experience with dieting, prompted in the large part by aesthetics rather than health. I come from a family who at various times would all be classed at some point to have been overweight, but it wasn't a topic of discussion in my family. I have since self-assessed as being in the obese category using one of the very many online BMI calculators, but at no point did any of the websites that I saw then alert me to some of the limitations of that tool. My experience of weight stigma has been internal and self-directed. The organisation where I now work did a survey called "Is Weight a Weight on Your Mind?", which obviously hit a nerve because we got about 750 responses. I took part in that survey, but opted not to leave my name to find out more about the project because I didn't want to think that my name was going to go on a list and be shared with people I'd previously worked with as somebody who was a consumer in this topic area, as obese. And then I began working at Health Consumers Council. The universe clearly had other plans for me in terms of how I would be telling my story. And I began a really steep learning journey, both by hearing from hundreds of people impacted by weight issues, and also by bringing a consumer lens to the evidence. When we asked people to share their stories of how their weight affected them, I wasn't prepared for the emotional impacts that so many people described. Person after person described negative impacts of their weight, often using words such as humiliating, fat-shamed, self-hatred, despair, anxious, judged, ugly, fat, worthless, not wanting to go out, concerned about what others think, stressed, overwhelmed. And what struck me about all these stories is just how different everybody's experiences were, but also how much I appreciated knowing that other people had similar experiences and similar feelings. It also lit a fire under me to do what I could to amplify and champion the voices of people with lived experience, including sharing my own lived experience, no matter how uncomfortable it might make me, and getting involved with the Weight Issues Network. Despite all my privilege, education and health literacy, as I've deep dived into all of this lived and learned experience, I've realised that everything I thought I knew about weight and health was, if not quite wrong, at least open to interpretation. That my inability to maintain weight loss isn't down to a personal moral feeling, but is in fact science. That the relationship between body size or weight and health is at best complicated and nuanced, and understanding it needs both clinical expertise and lived expertise of my context to make sense of it for me. That it's very unlikely that motivation alone will mean I can change my embedded behaviours while I live in a world that is set up to make it difficult to be healthy. And the fact that so many of us are taught that it is setting up many of us to feel like failures. And I've come to the conclusion that the biggest health danger in relation to weight and health is actually weight stigma, because it stops people of all body sizes getting the healthcare they have a right to and they need. And in many cases, weight stigma causes real health harm. I heard someone at a conference say that if you believe that every system is perfectly designed to get the results it gets, that if aliens were to land in Australia and try to work out what our food system is supposed to be achieving, then based on the results it's getting, they would assume our system exists to make some people unhealthy and other people rich. I heard someone else say at a conference that if we look at the work we've been doing in obesity, it's a little bit like we've been working where the light is, under the street lamp. But actually, it's now time to move beyond doing what can be done and moving into doing what needs to be done. Thank you.
All right. Thank you, everyone. That was our final presentation and ending with a bang. I hope that you learned something new from one of our amazing speakers, if not all of them. I hope that it's clear from all of this how complex obesity is, the need for collective action. I hope we've been clear that weight stigma is harmful and a barrier for all the things that we want to achieve. And I hope you keep being open to learning more. Thank you so much and have a good World Obesity Day. Thanks, everyone.